About to go live, sir.
Oh, we are
So,
live.
Namaste, sir.
Namaskar, madam.
Namaste.
Namaskar.
We are live, please.
so would you like to introduce the class first?
Yes. So, welcome on behalf of Haryana Ophthalmological Society. I welcome you all, ma'am, Dr. Nibha, Dr. Urmil, and Dr. Sharmishta ji, Dr. Swati, and of course, Dr. Sumit Lahane has not joined till now.
Sir is there.
Hello, sir.
Okay.
Very much here.
Hello, how are you, sir? And of course, Dr.
Sir, I'm good.
Raman Mittal and Dr. Sachi. So I welcome you on the platform of the Haryana Society and for this webinar of oculoplasty for the PGs of Haryana. So I think you can continue, Dr. Amita.
Yes, sir. I'll just share my screen again. So, good evening, everyone. Thank you very much, sir. And welcome to our webinar on orbital infections and inflammations. And I extend you all a warm welcome for this enlightening session. And my name is Dr. Amita Paul. I'll be your moderator today. And it is such a pleasure for us to have such a distinguished group of ophthalmologists, teachers, and eye care professionals from across the country and beyond. Now, whether we are here to deepen our understanding of diagnostic challenges or refine our management strategies, this webinar definitely promises practical insights that we can apply in our practice. Without much ado, I will now go on to introduce our chairperson for the day. Dr. Nibha Anand is a senior professor and head pediatric ophthalmology, squint and oculoplasty. Ma'am is based in Rohtak, PGIMS. She has over 23 years of postgraduate teaching experience and has been a professor at the RIO for more than 12 years. She has served as the organizing chairperson for significant medical conferences such as POSI events. Welcome, ma'am. It's again a pleasure for me to be introducing Dr. Urmil Chawla, ma'am. Ma'am is the co-chair for this session. She's the professor, Pandit B.D. Sharma, Postgraduate Institute of Medical Sciences, Rohtak. Ma'am specializes in pediatric ophthalmology, squint and oculoplasty, and she currently serves as the chairperson of the scientific. I'm so sorry, this is a mistake. Ma'am is not right now the scientific. Yeah, she's not right now. It's in the row, sir. Ma'am is an ex-chairperson of the scientific committee of the HOS, and with over 20 major publications, her research focuses on clinical topics like motor evaluation in strabismus and modern medical education. Our first speaker is Dr. Shachi Srivastava. She is the assistant professor, ESIC Medical College and Hospital, Faridabad. Ma'am is a prolific comprehensive eye care specialist and caters to specialized outreach activities like eye camps in hospitals. She's an avid trainer for residents and optometrists and contributes to hospitals' specialized clinical research and operations. Our second speaker for the day is Dr. Raman Mittal, sir. Sir is the director, Eyeplast Hospital, and is based in Amritsar. He is a distinguished oculoplastic surgeon and ophthalmologist with over 28 years of experience. Sir is a leading expert in ophthalmic cosmetic and reconstructive surgery, ocular oncology, and orbital diseases. And he's the general secretary of the OPAI. I now welcome the panelists.
Good evening,
Rajan Gupta,
everybody.
sir, our very own director of the Rajan Eye Heart and Laser Center, Tohana. He specializes in cataract surgery, LASIK laser treatments, and eye lens implants. And he currently serves as the general secretary of the Haryana Ophthalmic Society and has previously held the role of treasurer. I now welcome Dr. Sharmishta Behera, ma'am. Ma'am is a professor of ophthalmology in Vimsar, Burla, based in Sambalpur, Odisha. Her clinical and research expertise includes clinical ophthalmology, cataract surgery, glaucoma, and corneal diseases. Ma'am is an active researcher and reviewer with interest in neuro-ophthalmology, diabetic retinopathy screening, and complex reconstructive procedures like ptosis repair and orbital tumors. Our next panelist is Dr. Sumit Lahane. Sir is an ex-assistant professor, Sir JJ Group of Hospitals, and the director, Raghunath Netralaya, Mumbai. Sir is based in Mumbai. He's a prolific ocular surface, cornea, and oculoplastic surgeon. He's the ex-secretary of Bombay Ophthalmological Society and a managing committee member of MOS. He's also the ex-scientific committee member of the MOS and ex-organizing committee member of Oculoplastic Association of India. Dr. Swati Bansal is the next panelist. Ma'am is the additional director FMRI based in Gurgaon. She has approximately 20 years of experience and is one of the few surgeons in India with a dual fellowship in both oculoplasty and neuro-ophthalmology. Ma'am holds orbit oculoplasty and ocular oncology fellowship from Arvind Eye Hospital, Madurai, and a facial reconstructive surgery fellowship from Moran Eye Center, US. Ma'am also holds a neuro-ophthalmology fellowship from Singapore National Eye Center, Singapore. Welcome, ma'am. Our very own Dr. Inder Mohan Rustagi, sir. Sir is a veteran ophthalmologist and eye surgeon based in Rohtak, Haryana. He is highly regarded in the region with over 41 years of experience in providing comprehensive eye care and surgical treatments. And sir is also the convener for...
I'm based in Gurgaon, not in based in Rohtak.
I'll correct this, sir. So, sir is also the convener for postgraduate classes and chair of the scientific committee, Haryana Ophthalmic Society. With this, I now hand over the mic to Dr. Shachi Srivastava for the first talk.
Good evening, everyone. I'm Dr. Shachi Srivastava. I am from ESIC Medical College, Faridabad. I specialize in oculoplasty. And so today, with your permission, I would like to start my presentation. And thank you very much for giving me this opportunity. Is my presentation visible?
Not yet.
अभी नहीं.
Just a minute, just a minute. Is it visible now?
I think it is started. Yeah.
Just started.
Yes, so we'll discuss today about orbital infections and inflammations, their clinical subtypes, features, and pathophysiology. So basically, orbital infections and inflammations, they comprise a spectrum of disorders which range from benign preseptal involvement to life-threatening orbital apex and intracranial extension.
Make it full screen now, please, Dr. Sachi.
Pardon, ma'am?
Full screen, please. Slide show कर दीजिए.
डॉक्टर साथी स्लाइड शो पे करके फिर करो.
मैम कर दिया कुछ प्रॉब्लम हो रही थी. Is it fine now, ma'am?
Yeah, yes.
So basically, a little about the anatomy of the orbit. It's a confined bony compartment which contains critical neurovascular structures, including the optic nerve and the extraocular muscles. And there's close anatomical relation to paranasal sinuses, which predisposes to rapid spread of the infection. And increased intraorbital pressure can lead to optic nerve ischemia and permanent visual loss. And early recognition, accurate classification, and understanding of pathophysiology is very necessary for preventing vision and life-threatening complications. So in brief, some surgical anatomy, basically orbital septum is the barrier between the preseptal and the postseptal space. Subperiosteal space is the space between the periorbita and the bone. These are some important terms which we will come across in my presentation. Then obviously the intraguinal versus extraguinal compartment is important. The wall-less venous system, which leads to the increased risk of intracranial extension, and lamina papyracea, this thin ethmoidal wall vulnerability predisposes to the spread of the infections. So what is the intragonal space? Is the space between the muscle cone formed by the recti, then the extragonal space is outside the muscle cone, then the subperiosteal space, preseptal versus postseptal space. So these are important spaces which we need to remember when we are dealing with orbital infections as well as inflammations. So orbital infections are primarily classified using the Chandler's classification, and it is categorized by severity based on the anatomical location, which is relative to the orbital septum and presence of the abscess. So the 5 stages are, group 1 is the preseptal cellulitis, group 2 is orbital cellulitis, third is subperiosteal abscess, fourth is orbital abscess, and fifth is cavernous sinus thrombosis, which is the most severe complication and it's life-threatening too. This is the diagrammatic representation of the 5 stages of the described by Chandler. Now coming to the preseptal cellulitis. Preseptal cellulitis is an inflammation of the tissues located anterior to the orbital septum. And the pathophysiology, there are 3 main routes for the pathogen inoculation in the periorbital tissues. The first is by direct inoculation after eyelid trauma and infected insect bites. Second is spread from the contiguous structure, which is very common, which mainly is from paranasal sinuses, especially the ethmoid. Since the nerves and vessels, they traverse the lamina papyracea that divides the ethmoid sinus from the orbit. So this is a continuing feature. On other various infections which affect the eyelids and eye in general. So this is the route of spread, how it spreads from the paranasal sinuses, then supine of ophthalmic veins, then ultimately it goes to the cavernous sinus. So the majority of these infections are caused by bacteria. Adenovirus, herpes simplex, and varicella zoster may also be implicated. In immunocompromised patients, fungi may also be a possible etiology. Gram-positive cocci are the most prevalent microorganisms, especially staph and streptococcus species, pyogenes, and pneumonia. Staph aureus and epidermidis are commonly found after penetrating eyelid trauma, and streptococcus pneumoniae is seen secondary to sinusitis. And before in the children who are not immunized against H influenza, it is also a common cause of preseptal cellulitis. So how do we diagnose? Patient usually complains of eyelid swelling and redness, but the classic signs are there is mainly eyelid erythema, warmth, and fever. The clinical keys that distinguish between preseptal and orbital cellulitis are there is no proptosis, absence of proptosis, pupil with normal reaction to light, normal color saturation, normal conjunctiva, no chemosis, and normal ocular movements. These are very important points. Now we come to the orbital cellulitis. So orbital cellulitis is a serious infection which involves the muscle and the fat located within the orbit. It is also sometimes referred to as post-septal cellulitis. It may or may not progress depending on the stage at which the treatment has been taken. The causative organisms are mostly bacterial, but can be polymicrobial, which can include both aerobic and anaerobic bacteria and even fungal or mycobacteria. Most common organism again is Staph aureus and Streptococcus species. And rare cases have been reported with non-spore forming anaerobes. Fungal pathogens cause invasive orbital cellulitis, including mucorales, which cause mucormycosis, and aspergillus, which can cause life-threatening invasive orbital infection. Another rare cause of orbital cellulitis is mycobacteria, MTB, especially in immunocompromised patients. So most common cause of orbital cellulitis is the bacterial rhinosinusitis. Other potential causes can be infection of the teeth, middle ear, face, dacrocystitis, any trauma, ophthalmic surgery, mainly extraocular surgeries, peribulbar anesthesia, any infected mucous seal that erodes into the orbit, immunodeficiency, and it is commonly seen in young children and usually it is less common in older children and adults. It most commonly occurs in the setting of upper respiratory or sinus infections, which I have already discussed. So these infections, they occur basically in the upper respiratory tract. It is colonized by Streptococcus pneumoniae. An infection, it can occur through various mechanisms, and it also occurs in the primary in the respiratory tract. So these are various places from which the bacteria can lead to the spread of infection. Staph aureus infections occurs in the skin, and it spreads to the orbit from the skin. Staph organisms, they produce toxins that promotes their virulence, and it leads to increased inflammatory response seen in these infections. And the inflammatory response elicited by all these pathogens plays a major role in tissue destruction in the orbit. So the history will be a classical of a painful red eye with lid edema in a child with recent upper respiratory infection with typical presentation of orbital cellulitis. They will also be complain of headache, orbital pain, double vision. There will be restricted ocular motility because of which the patient complains of double vision. Then there is obviously progression of symptoms. There may be a history of recent upper respiratory symptoms, fever or lethargy. In addition, any recent trauma or injury should be inquired about. Family or healthcare contacts with MRSA, any history of sinus, ear, dental or facial infections, any recent surgery, any pertinent medical conditions and current medications, they should always be inquired upon, like diabetes and immunodeficiency. And specific questions should always be asked about any change in the vision, mental status, any pain with the neck movement or nausea or vomiting. It should also be noted. So now again coming to the clinical features, diminished visual acuity, proptosis, RAPD may be present. There may be affection of the color vision as well, chemotic conjunctiva, reduced extraocular movements. Cellulitis may extend to the cheek and forehead, and it is common to see an eyelid abscess. So as the symptom progresses, the inflammatory signs, they increase. There's further increase in the redness and swelling of the eyelid with a proptosis. As infection worsens, the extraocular motility is also hampered. When optic nerve is involved, then visual acuity is also lost. And the intraorbital pressure may increase, and the orbit may become resistant to retropulsion. The skin feels warm to touch, and pain can be elicited with either touch or eye movements. An examination of nose and mouth is always warranted to look for any black scar which may suggest a fungal infection. And purulent nasal discharge with hyperemic nasal mucosa may be present in these kind of patients. I've seen 2-3 cases of orbital cellulitis in children who were diabetics. And one of them had mucormycosis, and eventually she had to undergo exenteration because it was very severe, and she had a cavernous sinus involvement as well. So this point should never be missed. You should always go for a nose and mouth examination in these patients. Now the advanced stage is subperiosteal abscess, which can be post-orbital cellulitis. There's collection of pus between the periorbita and the orbital bone. It is most commonly secondary to ethmoid sinusitis. The infection spreads through the lamina papyracea. There is elevation of the periorbita and there is localized pus accumulation. Medial orbit is most commonly involved. The raised intraorbital pressure leads to risk of optic nerve compression and vision loss in these patients. Clinical feature, there is worsening of proptosis, which is usually non-axial. There is painful and restricted extraocular movements, again the same, and there is obviously worsening in these patients. Now, the dreaded complication is the cavernous sinus thrombosis. It is a rare but life-threatening condition and requires urgent recognition and intervention. It can occur as complications secondary to underlying septic conditions, which can include facial infection, sinusitis, orbital cellulitis, pharyngitis, otitis, or even from aseptic causes such as trauma or surgery. So there can be varied causes for CST, but orbital cellulitis is one of the common causes for that. So anatomy of cavernous sinus is very important. The cavernous sinuses are located on either side of sella turcica and they are above and lateral to the sphenoid sinus. The anterior demarcation is by superior orbital fissure and posterior is by the pectoris apex of the temporal bone. And the inflow is by the superior and the inferior ophthalmic veins and anteriorly from the superficial cortical veins. And the outflow is from the basilar plexus posteriorly via the superior and the inferior petrosal sinus. So basically we see the sinus has vast connections and this is how it receives the infection easily and it helps in the spread of the infection intracranial, which is very fast. So there is embolization of bacteria and other infectious organism, which causes thrombosis and subsequently trap infection within the cavernous sinus. And in many cases, when there is involvement of the face also, there is decreased drainage from the facial vein, superior inferior ophthalmic veins. Then there is facial and periorbital edema, proptosis, chemosis, discomfort. So basically, these are all sequelae which happen after there is involvement of the cavernous sinus. And the lack of valves in the dural sinus system allows for blood flow through the emissary veins into and out of the cavernous sinus, and thrombus can propagate into the dural system. Communication between the right and left cavernous sinus via the intercavernous sinus located anterior and posterior sella causes the spread of thrombus and infection from the one side to the other. So presentation is similar, but there are systemic features which are marked. There is fever, headache, altered sensorium. Additional signs can be rigors, vomiting, severe cerebral symptoms. Transference of symptoms. Symptoms may transfer to the fellow in 50% of cases, which is very, very important diagnostic sign of CST. There's paralysis of opposite lateral rectus, severe supraorbital pain, and paralysis of the ocular motor nerves. This is the diagnostic criteria of the cavernous sinus thrombosis. In later stages, there is immobility of the eye, there is dilated pupil, there is corneal anesthesia, there is late onset proptosis in otitic cases. Retinal veins may show engorgement, but may not always be present. But if present, it indicates extensive orbital vein and tissue involvement. And papilledema is common in otitic cases, and it indicates meningitis or cerebral abscess, which is very, very lethal. Orbital apex, if the apex of orbit is implicated, then various ocular motor palsies may develop together with the trigeminal anesthesia and neuralgia, and occasionally amaurosis due to the involvement of the optic nerve. So in orbital apex, usually the optic nerve is involved and patient loses vision very quickly. Now we come to the orbital inflammations. Non-specific orbital inflammations are also known as orbital inflammatory pseudotumors or IOI, and orbital inflammatory syndrome is the most common cause of painful orbitopathy in adults. NSOI can affect various types of orbital tissues. It may be categorized by location within the orbit, which is anterior, diffuse, or apical, or the tissues affected, which is dacroadenitis, myositis, posterior scleritis, optic perineuritis. The lacrimal gland is affected most frequently in 32% cases according to various studies, with extraocular muscles a close second, that is 29%. The etiology and pathogenesis of NSOI is not very clearly known. Both infectious and immune-mediated etiologies have been implicated. Another suggested theory is molecular mimicry, the development of an antibody that cross-reacts with both a microbial protein and normal host tissue. It may arise after an acute infection, and it has been observed in association with a variety of rheumatologic conditions like Crohn's, SLE, RA, myasthenia, and ankylosing spondylitis. So the clinical features are it may present in acute, subacute, or chronic fashion. It is usually unilateral, but bilateral disease can occur and it has an incidence of 8% to 20%. It is usually seen in the 5th decade. There is no sex predilection. However, orbital myositis most commonly affects the young adults in 3rd to 4th decade of life and shows female predilection. It may present with a wide range of symptoms. So anterior IOI mainly affects the globe, conjunctiva, eyelids, neural and adjacent muscular structure. Patient presents with pain and periorbital swelling, and it also includes conjunctival chemosis and limited ocular motility. Rarely, proptosis, uveitis, papillitis, and exudative RD can also be seen in these patients. Patients with diffuse IOI present with features similar to the anterior IOI. However, the findings are more severe in diffuse cases, and proptosis is seen more frequently with diffuse variant compared to the anterior IOI. Apical or posterior IOI, while less common, is associated with a poorer visual outcome, and clinically it presents with orbital pain, restricted eye movements, visual loss, and minimum proptosis. Inflammatory lesions of the orbital apex may extend intracranially through the superior orbital fissure, optic canal, and the inferior orbital fissure. The cavernous sinus and middle cranial fossa are the two most common locations for the intracranial involvement in these cases. Tolosa-Hunt syndrome is a rare critical clinical condition which is characterized by idiopathic granulomatous inflammation in the region of cavernous sinus and or superior orbital fissure. It presents with relapsing or remitting partial or complete ophthalmoplegia, vision loss, and unilateral headache. Myositis involves single or multiple extraocular muscles. Clinically, it presents with unilateral orbital or periorbital pain, diplopia or ocular motility restriction, proptosis and eyelid swelling, and the conjunctival injection at the site of the tendon insertion. The most frequently involved muscle is the medial rectus, followed by superior, lateral, and then inferior rectus muscle. Isolated LPS muscle involvement has been seldom reported. So this is a case of myositis. In this, we see there is upper eyelid swelling, proptosis, and conjunctival injection. And the T1 weighted axial MRI demonstrates the enlargement of the right medial rectus muscle, fusiform enlargement. Dacroadenitis is the most commonly encountered subtype of IOI, as I had previously told. Approximately 50% cases of all IOIs. The typical acute presentation is firm, painful, erythematous mass with edema in the upper lateral eyelid and S-shaped ptosis sometimes associated with dry eye. In 20% of patients, both the lacrimal glands are affected, either simultaneously or sequentially. A subset of patients with initial diagnosis of idiopathic dacroadenitis, they have been also labeled as IG4-related dacroadenitis. So it's immune modality which is associated with it. IG4-related ophthalmic disease most frequently involves lacrimal gland, but can also affect the orbital soft tissue, optic nerve, trigeminal nerve branches, and other infraorbital nerve, sclera, choroid, and orbital adnexa. Now the periscleritis, it is the inflammation which involves the sclera, uvea, and or Tenon's capsule. The clinical features they include orbital pain, exophthalmos, eyelid edema, vision decrease, and associated uveitis. Optic perineuritis is also known as perioptic neuritis. This is another spectrum. It is a rare idiopathic orbital inflammatory disease in which the specific target is the optic nerve sheath rather than the optic nerve axons, as occurs in optic neuritis or optic neuropathy. Optic perineuritis usually presents with pain, swollen optic disc, and arcuate and paracentral visual field defects. OI may also present as focal inflammatory mass in the orbit, which is a non-specific presentation. The clinical presentation varies according to the location and the extent of the mass, and the resulting symptoms are related to the mass effect and the inflammation or infiltration. Clinically, a space-occupying or infiltrating focal mass may present with proptosis, motility disturbance, optic nerve compression, and other inflammatory signs which include edema and hyperemia. So as you can see, there's proptosis in this patient because of local focal mass, and after this mass was excised, the proptosis has reduced because this mass was in the inferior rectus, but however, he has developed some hypertropia. A small subset of IOI is associated with sclerosing orbital inflammation. It produces severe morbidity with a severe chronic progressive disease, which is often characterized by proptosis, mild inflammatory signs, restricted ocular motility, and pain. Due to progressive nature of the disease, it may present as diffuse orbital involvement or with extraorbital involvement. So IOI is uncommon in pediatric age group, usually characterized by bilateral involvement in children. It differs from adult presentations. Constitutional signs may be seen in up to 50% of the patients. Optic disc edema, uveitis, and eosinophilia, they are more common in pediatric population. And DDs also include cellulitis and tumors, which have to be kept in mind in these patients. So the conclusion is that orbital infections and inflammations, they present a spectrum which ranges from localized preseptal disease to life-threatening orbital apex and intracranial involvement. The confined orbital anatomy and valvulus venous drainage, it facilitates rapid spread and optic nerve compromise. Understanding pathophysiology is critical for early recognition of the red flag signs such as painful ophthalmoplegia, proptosis, and visual deterioration. Timely differentiation between preseptal and postseptal involvement guides appropriate imaging and the management. And early intervention is very essential to prevent irreversible visual loss and potentially fatal intracranial complications. Thank you very much.
Thank you very much, Dr. Shachi. Ma'am, if you'd stop screen sharing, I would now like to invite Dr. Raman Mittal, sir, for discussing the management part of the orbital infections and inflammations.
Good evening, ladies and gentlemen. Actually, my previous speaker has spoken so nicely that I believe I can end up my speech in just 2 lines saying, if there is orbital infection, give high dosage of antibiotics. And if there is an orbital inflammation, add on the steroids along with. So anti-inflammatory is very important along with the antibiotics. She has, I was throughout her presentation, I was thinking that we should have made it clubbed because the sequence which she has made is exactly the same sequence which I'm going to talk upon. So we could have clubbed that she says about how the categorization is there and next the management is there. Anyways, as I go by, allow me to share my screen. Okay. Due to lack of paucity of time, I just made it very bland. I could not make a lot of pictures in it. So is my screen visible?
Yes, sir.
Okay. So I would be talking mainly on the management. So introduction, she has given that there is infections as well as inflammatory disorders, and some of them become very true emergencies. Delay should not be there, and improper management can lead to permanent vision loss, intracranial spread, cavernous sinus thrombosis, and even death. So as she has rightly mentioned, most of the cases arise from paranasal sinuses infection, especially from the anterior ethmoidals and the nasal sinuses. Understanding the, one second. Yeah. So understanding anatomy explains spread, symptoms, and complications. So, and the key structures which we need to know is the orbital septum. This is a very important sheath which separates the islets from the orbit. Primarily, this is the primary barrier between the preseptal and the orbital diseases. And of course, the lamina propria, which is a thin medial wall, because the infection in ethmoids can easily spread to the orbits. And there is some venous drainage into the orbits, which are the valvulus veins. So they can lead on to the spread of infection to the cavernous sinus. So when we know this all, you can say the neighborhood of the orbit, then we should know that there is some relevance to the neighboring structures. So any infection posterior to the orbital septum is potentially vision and life-threatening. Classification, she has already mentioned about the Chandler's classification, so I'll skip this. Preseptal cellulitis, as she has mentioned, local skin trauma, insect bite, lesions spread from upper respiratory tract infections. Clinical features, she have mentioned it. So the main thing which we need to investigate is, apart from the usual clinical features, you can see the CT which diagnose it, whether it is going into worsening condition or not. And the management remains primarily the broad spectrum antibiotic good coverage. Cephalosporins can be taken care of. And if we need, then we can go in for linolid and all that type of higher antibiotic. You should try to treat the source in case you find it. And a close follow-up is important because a preseptal cellitis can further lead on to the orbital cellitis, especially in cases of, sorry, forgive my nasal twang and a bit of upper respiratory tract infection. So the example being absence of proptosis and the painful eye movements. This differentiates preseptal from the orbital cellitis. So if you have a case of, you know, swollen eyelids and painful things, then you should see whether their eye movements are involved or not. This chap seems to be very in a very bad situation with the worsening condition. But if you see the lids, open the lids and see the movements of the eyeball, they'll be normal. So it's a preseptal abscess. If you simply drain off the abscess, give a good source of antibiotics, the child becomes quite better. You see in the post-op picture. Whereas orbital cellulitis is like a true emergency. Generally, the ethmoids are the common cause, could be because of the trauma or the dental infection, which may lead on to the endogenous infection. Or in case of post-surgical hematogenous spread, the common organisms, as mentioned, staph and strepto. Clinical features apart from others are proptosis, painful restricted eye movements. This is very important. The patient may have restricted eye movements in one particular gaze or in all the gazes, and sometimes the movements are painful. The vision may or may not be decreased, but sometimes they may present with visual involvements, whereas in preseptal, there is no visual involvement generally. But because of the, you can say, poor lid hygiene or poor lid health, sometimes the patient may decrease down to one or two lines. Fever, chemosis, lid edema, RAPD is there sometimes if the optic nerve is involved. Red flags, any restriction of the eye movements plus pain that suggests the orbital involvement until proven otherwise. So the investigations here, because the management means the clinical diagnosis and then the treatment. So apart from the simply jumping into the treatment part, the management also includes the investigations. Mandatory CT orbits plus or minus PNS with contrast gives you a good, you can say, insight what you are dealing with. Sometimes people generally ask whether you should go in for a CT or an MRI. That's a very routine question of the general ophthalmologist. MRI can also give you a good picture, but it is slightly longer, expensive, whereas CT gives you nearly all the information which you want. So CT is easier. But if you are, wary of radiation hazards, then you can go in for MRI as well. So you should look about for fat stranding, muscle enlargement, and whether there is abscess formation or not. Because in case of abscess formation, you need to drain the abscess and then start along with the treatment, you should also drain the abscess. Otherwise, your treatment will not result in good results. And also you do the blood cultures, nasal swabs if the sinus disease is there. Medical management is the first line of management. In case you have hospital admission facilities, you can get it done. It's not compulsory though. IV antibiotics, broad spectrum, ceftriaxone, cefotaxime, vancomycin, MRSA, metronidazole. You should cover the anaerobes as well. Here, I would suggest generally we don't cover the anaerobes. Amikacin or metronidazole should be given till the time you receive the pus cultures. IV may be required 7 to 10 days also, but sometimes 3 to 5 days are good enough. That depends upon how the patient is, responding to your treatment. Thereafter, you can continue with the treatment orally. The supportive care is head elevation, analgesics, lubricants because the proptosis sometimes lead to the exposure keratopathy. Vision monitoring should be done every few hours. It's not that once you admit the patient and thereafter on third, fourth day you do the visual monitoring. This is very important, both clinically as well as medical legally. So role of steroids, it is very important. Now, I would like to emphasize that steroids, I would say, are very important in the management of all types of orbital cellulitis or even preseptal cellulitis. Itis means inflammation, and steroids remain a very good anti-inflammatory. Some of the ophthalmologists do not like to give steroids. They think that they will spread the infection. But if you give a good antibiotic coverage, then you can give a good steroid cover as well. So if not started, steroids, if not started initially, may be added 24 to 72 hours after the antibiotics are given so that you have adequate antibiotic dosage in the body, or you can give a bolus cover up to the antibiotics and then start the steroids. But steroids remain the mainstay of the treatment. So this is again a viva trap for the PGs, I would say, that steroids without antibiotics can worsen infection. Yes, of course. But you should give antibiotic coverage, a good broad spectrum antibiotic coverage. Because it's a dual, we all know that it's a double-edged sword. So steroids are important, but then you should have a coverage as well. I will skip the pathophysiology of subperiosteal abscess, but mentioning it that the pus accumulates between the bone and the periosteum. Generally, it's in the medial wall because we have sinuses from there. The clinical features being increasing proptosis, diplopia, reduced vision, failure to improve on antibiotics. CT findings give you a lenticular collection along the orbital wall. So it will be, you will find it out a very clear-cut demarcation from the anterior in the orbital wall. And the management depends upon the age and the size of the orbital abscess or the subperiosteal abscess. Children less than 9 years generally have smaller abscesses. They can be treated with medical trials. And if they are
So your voice is breaking up.
Ma'am, actually, I'm in Ranchi and I'm trying to connect with my mobile phone.
So
I
can you
guess
please switch off your video for some time? So if the video is off, we'll get a little bit better reception of the voice. I'm really sorry.
no, it's fine, it's fine. वैसे भी मेरी शक्ल इतनी अच्छी नहीं है. Let me
That is
see.
absolutely not the case.
I think I'll have to
Sir, I've
stop.
stopped the video.
You
Yeah.
have stopped it?
Thank you so much, sir.
Okay, 1 second. I also need to charge my mobile, to which I'm taking the hotspot, otherwise it will go off. Okay, fine. So where we were, yeah. So indication for surgery is if there is a visual deterioration, RAPD, large abscess. This is, I will say, relatively because even if it's a smaller abscess, because I have all the facilities, I go in for abscess drainage. And if there's no improvement, then you should go in for abscess drainage. Then orbital abscess, apart from the preseptal, then you go for the periosteal and subperiosteal, now the orbital abscess. There may be severe proptosis and marked ophthalmoplegia because the abscess is now in the orbit, involving the muscles very much. Vision loss could be there. The patient is quite toxic. This is in the emergency care. You need to do the surgical drainage and good antibiotics, IV antibiotics. This is an surgical emergency, okay? So, as she has mentioned, cavernous sinus thrombosis, it can spread via angular veins. Staph aureus is the most common. Bilateral eye involvements is there. Patient may present to you with severe headache, diplopias, sometimes vision loss. All these cranial nerve palsies can be there. And papillar edema, as she has mentioned, is one of the pathognomonic signs. In this management, you have to do a very high dosage of antibiotics, IV, and anticoagulation remains very important. And ICU care is also important. So generally, when I deal with these type of patients, I involve the intensivist along with the neurosurgeon if possible. I have a friend, so we have that setup. So in these type of cases, we work as a team. It's always good to work as a team. Excuse me, please. Just 10 more minutes. Yeah. So, fungal orbital infections, as we know, mucormycosis, especially we had the wave of mucormycosis after the COVID. The risk factors being the diabetes and the high steroid usage. And if the patient is immunosuppressive, then all these fungal come in. It's we should understand that fungus is always there in our body, but it props up if we are immunocompromised. Clinical signs being facial pain, blackish shower, and rapid orbital movement loss. And here it's again uh, it's an emergency. So liposomal amphotericin B is the mainstay. We all know after the COVID wave, aggressive surgical debridement is important. So sometimes you need to do aggressive surgical debridement only, but sometimes you should control the blood sugars. The golden line is the delay in management kills. If you end up wasting time giving the management before the management is done by doing the investigations and all, you may lose a very valuable time. Orbital inflammatory disease, which is non-inflammatory, idiopathic orbital inflammatory disease, is called pseudotumor. Nowadays, pseudotumor is not the term used internationally. It's non-specific orbital inflammatory disease, NSOIDs, which that is commonly used. And autoimmune inflammation is one of the most important thing. Clinical features, she has already mentioned: painful proptosis, red eye, ophthalmoplegia, no fevers. CT MRI shows us diffuse involvement of the lacrimal gland, fat sometimes, or the muscles. Management in this case is mainly steroid rather than antibiotics. So this is a non-infective. So you have to first differentiate between the infective and the inflammatory disorders so that you know what is your mainstay of treatment. If you can differentiate or diagnose that well, that saves you your own reputation, and then you benefit the patient. But in case of doubt, you should always add on the antibiotics rather than not doing it. Okay, so high dose of systemic steroid should be given. Sometimes we don't give enough dosage. We just give 10 milligram, 20 milligram of Isolon. 1 milligram per kg body weight can be given per day. I start these type of patients on IV methylprednisolone pulse dosage as well sometimes. So the dosage of steroid has to be optimal. Again, classical Viva line, as this is a PG class, pseudotumor responds dramatically to steroids. Yes, that is very important to be known. Orbital myositis, again, the movement of the eyeball would be painful because this is involvement of the muscle. One or more involvement muscles can be involved. Tender sparing can be there on imaging, but mostly it is tendon is involved. Oral steroid is giving an excellent prognosis. Here you see a picture where you see the muscle insertion is inflamed, and in ultrasonography you see the enlarged muscle as well as the tendon is involved. So when the tendon is involved, it is myositis. When the tendon is paired, it is more towards the thyroid eye disease. So now in this case also myositis, steroids remain the mainstay. Depending upon the type of myositis, the involvement of muscles, you can decide whether you want oral or systemic IV anti-inflammatories. Thyroid eye disease, I've covered it in detail because this is still remains the most common orbital inflammatory pathology. It's mainly an autoimmune inflammatory disorder of the orbit, most commonly associated with Graves' disease, but it may occur in euthyroid patients also, and even in hypothyroid patients. This line again, I should have mentioned in red because most of our ophthalmologist colleagues thinks that it's only that hyperthyroidism causes thyroid eye disease. No, it is not the case. Even hypothyroid patients may have thyroid eye disease, or even a euthyroid patient may present to you with all the ocular symptoms of thyroid eye disease because it's just like a patient with diabetic mellitus who has been well controlled can still present to you with diabetic retinopathy and diabetic related disorders. TED is independent of thyroid hormone levels and follow its own natural course. Epidemiology, females are more prominent, you find females more 5:1 ratio. Severe disease is more common in males, though peak age is 30 to 50 years. Smoking is the strongest modifiable risk factor. So this is one important thing which you should ask for the history. And in some part of our country, like in UP, Bihar, and all, Even females smoke a lot. So you should, even for female, you should ask the history of smoking. Etiopathogenesis is very important because it's an autoimmune mechanism. So autoantibiotics target the TSH receptor, IGF-1 receptors on the orbital fibroblasts. Pathognomic changes is mentioned, the edema of the muscle and fat, fibrosis in the late stage. Generally, muscle are involved. The muscle belly is involved more than the tendon, but yes, the orbital fat can be involved. So here the key distinction is the muscle belly is enlarged, with tendon differentiate from the TD from the orbital myositis. Smoking, dose dependent, radioiodine therapy, if you're not covered with steroid, or there's a poor thyroid control. Female gender, as I mentioned, has a larger preponderance. This is a picture showing that the patient may present to you with ptosis. This lady presented to me with saying that the one eye is drooping down, but actually what she had was the other eye retraction. So you should be knowing which eye is, which eye is having the pathology. So on MRI, she had this enlarged muscles, and on ultrasonography, ultrasound is very important because when you follow the patient, you cannot keep on repeating the MRI, so you should have an ultrasonographic backup. Clinical features I will skip. She has mentioned lid retraction is very important, and extraocular movement involvements are there. Classification I will mention, I'll skip. So investigations, T3, T4, TSH, THS receptor antibodies is very important. Imaging, CT or MRI should be done, and that is also again important for your follow-ups. Generally, you see the muscle belly enlargement, tendon is paired, apical crowding could be possible. Coca-Cola bottle appearance. If you remember the old Coca-Cola bottle, that is the typical appearance of the muscles. Here, the management is that you should, apart from giving whatever you want to, the control of thyroid status is very important. I always tell my patients, whatever I may do, if your thyroid status is not very well controlled, my all my efforts will go into vain, or they'll be affecting only partially. If the patient is a smoker, ask them to stop smoking. I generally tell them, if you want to, have no effect of medicines, if you want to die of this disease, then you can continue with smoking. You have to quit smoking, not just decrease smoking, but they have to quit smoking. You have to treat it according to the activity and severity. More active the disease, the better is the result of the IV methylprednisolone. And sometimes you need a multidisciplinary care. So in the initial mild disease, lubricating eye drops, selenium supplements, head elevation, and smoking cessation is important. But in case of moderate to severe disease, apart from this, you may need to add on systemic corticosteroids. I prefer giving IV methylprednisolone as a pulse dosage. And sometimes if you are not able to give high dose of methylprednisolone, immunosuppressants in other ways can be done. Orbital radiotherapy, there are two schools of thought. One school of thought, they feel that the orbital radiotherapy is good, whereas the other school of thought thinks that that leads to fibrosis. So this is a personal, I would say, you can say personal choice which you make. I personally don't prefer orbital radiotherapy. Steroids are quite effective, but only in the active phase, as I've mentioned. Whenever there's activity, steroids will be more active. Sight-threatening TED emergencies, you can, in cases of optic neuropathy or severe corneal exposures, give very high dosage of methylprednisolone, even daily dose of 1 gram of methylprednisolone for 3 to 5 days you can give. Otherwise, you may need to go in for an urgent orbital decompression if there is not much of response. In
So,
this
excuse me,
lady, sorry,
sir, my apologies for interrupting you, but we still have the discussion pending. So, how many more slides do we have?
I think 3 or 4 more slides.
All right, sir. So sorry, sir.
I'll skip over in those cases. This is one which I would like to show you that in this case she had a squint because of thyroid eye disease, And you see that the muscle bellies are quite enlarged and tendon sparing. So with good dosage of steroid, she went from both exo into a normal eyes. So that is how the steroids can give you good effects as well. So I'll skip this. And sometimes whenever you need orbital decompression, you should be ready to do it. Dacryoadenitis again is a very common feature, generally seen in very young adults, young females, I would say. It is generally idiopathic. Other differentials are sarcoidosis, Sjogren syndromes, IgG4 related disease. S-shaped ptosis, as she has mentioned, is there. Dry eye symptoms can be there. Imaging gives you only lacrimal gland enlargement, but sometimes it is extended into the orbital cavity as well. So management remains systemic steroids, and you should treat the underlying systemic disease. In IgG related orbital disease, lacrimal gland again is the most common structure involved. So the clinical features becoming the painless swelling, sorry, bilateral involvement or chronic course. Raised serum IgG4 is very important to differentiate it from the other inflammatory diseases. Sometimes you need to do a biopsy to see whether it's a lymphoplasmatic infiltrate, and management still remains the systemic steroids. Rituximab is sometimes used in resistant cases. So we should always rule out IgG4 disease in bilateral lacrimal gland disease. Okay, sarcoidosis, here we should do the chest x-rays and see the elevated ACE levels. Again, management remains steroids. Granulomatous diseases with polyangiitis. Red flag is orbital inflammation with nasal crusting. Think of GPA. Management still remains systemic immunosuppression. Orbital lymphoma, it's a non-infective neoplastic disease. So here the Salmon patch appearance of the conjunctiva is very important. And here in this, as you see, there's a pinkish mass and it was going beyond the retrobulbar area. If you take the biopsy and if you diagnose it, then you need radiotherapy and chemotherapy, depending upon whether it is systemically spread or not, and they respond very well after the management. So that is what I have suggested. Take home messages that you should differentiate between the periseptal versus the orbital. CT scan is mandatory in cases of orbital cellulitis is suspected. Vision is to be monitored. Bilateral lacrimal disease, you should think of IgG4 and sarcoidosis and just not jump into the diagnosis of dacryoadenitis. Biopsy, if needed, you should perform. Steroids once the infection is controlled, and multidisciplinary approach is essential. Before I close, I would request all of you to also support me and vote for my candidature of member scientific committee. Thank you very much for giving me this platform. Here I stop sharing my screen.
Thank you very much for that exhaustive uh, lecture, sir. And I'll now throw open the discussion for the panel first, and then I'll ask for expert comments from the chair and the co-chair. So my first question to the panel would be,
Can you
um,
start my video now?
yes, sir. Yes, sir. Absolutely, sir. So, Dr. Swati, ma'am, how do cyanogenic versus hematogenous spread contribute to orbital infections? And in your clinical experience, which pathogens have you seen more commonly in each kind of?
So yeah, basically in small children, sinus spread is more common. So that is why a CTPNS is indicated. And more than often, an ENT consult is required. And sometimes they even require a FES. I have personally seen children who have pansinusitis, and whatever said and done, how many antibiotics you give, sometimes they do require to undergo a FES, definitely. That is why in orbital cellulitis, CT is of prime importance. I usually do a CT for all patients of orbital cellulitis. MRI is reserved only for patients who show any early signs of neurological involvement or a bilateral involvement if we are suspecting cavernous sinus involvement. But CT definitely is indicated. And in my experience, mostly gram-positive cocci are the most common organisms. But sometimes there is an anaerobic component. Sometimes, as Dr. Shati said in her talk, it could be polymicrobial. So we have to give a broad spectrum antibiotic, and for older kids also give a anaerobic cover.
Right, ma'am. That's a point well taken. Sharmisha, ma'am, just now, Dr. Swati said, it could be a polymicrobial infection. So, and children, whenever they have these infections, they might need FES more often than not. So, according to your clinical experience, how does the management of orbital cellulitis differ in children, say, who are less than 2 years of age compared to older children? Particularly regarding hospitalization criteria in your clinical practice, sinus drainage.
See, I work in a government medical college,
Right, ma'am.
and I was a guide to a topic of orbital cellulitis um, in a tertiary eye care center. So, clinical profile as well as the management. So, that was during the COVID time. So, as we started the study, we got rampant staph aureus as the cause. And every case we would do a culture and only then start the antibiotic. But most of the cases, as you know, in tertiary care, they already come after taking antibiotics. And polymicrobial, we actually never came across, possibly because of these pre-treated cases. But later on, we found a lot of cases of mucormycosis where amphotericin was the treatment, transconjunctival amphotericin B. So this is my experience with orbital cellulitis. And during the COVID times, we did MRI for all the cases. And as a protocol, we would send all the cases to the ENT department to rule out any type of sinus involvement.
Right, ma'am. Right, ma'am. So, on that note, I would like to bring in Dr. Sumit, sir. Dr. Sumit, sir, are you there?
Yes, tell me. Yeah, I'm there.
So I was wondering, like you have also worked a lot in a government-based setup, so I'm sure you've seen a lot of immunocompromised patients, and like ma'am was saying, we usually see monomicrobial rather than polymicrobial infections. So when you would be seeing a patient, and usually the history of immunocompromise is not that forthcoming. So what clinical or imaging features would raise suspicion in your head? Thinking, okay, this might be the patient not giving history, like might be immunocompromised patient, and this might be a case of, say, fungal sinusitis extending to the orbit, which I might be seeing.
So here I suppose you're talking about opportunistic infections.
Yes, sir, basically.
Yeah. So generally, we'll go stepwise. A patient is very cachexic in general, loss of buccal fat mucosa, and you see emaciated patient. That is one thing. Secondly, those patients will be more toxic, like their fever will be not responding to the antibiotic. Generally, these patients get admitted with the physician, and then we used to get a call that so and so patient is not getting responded to our antibiotic treatment. That is another thing. Thirdly, like in like ma'am said, in cases of COVID, we saw a lot of mucor, but those prior to COVID were more into diabetics. Now it is everywhere, and small viral infection also can suddenly trigger those kind of mucor cases. So in those cases, your imaging becomes very important because every time you may not see that amount of proptosis because it starts in the sinus. So resistance to your antibiotic, a more toxic patient generally point out that you are looking at certain opportunistic infection, and do have other infections like pneumonia, and in general their immunity is very low for any kind of infection. So when you see this kind of infection, you do suspect that you are looking at a immunocompromised individual.
Right, sir. So, question is open to the whole of the panel and Urmil ma'am and Niba ma'am as well. Is there any role for blood cultures or, like, say, sinus aspirates or orbital biopsy in confirming whether it is a polymicrobial versus a monomicrobial infection in adults? And, like, what do you do in your clinical practice, whether it's blood culture or sinus aspirate or orbital biopsy in certain cases? maybe Urmil ma'am first, and then we can put the question to the rest of the panel. Ma'am, you're muted. Ma'am, please unmute yourself.
Okay, initially I just wish to thank you for giving me the opportunity to be here, and both the talks were very nice, very comprehensive, and they've covered everything. And since this was a PG class kind of thing, so the first thing which I'll obviously answer your question, I feel that for the PGs, they should initially definitely know to differentiate between preseptal and the postseptal orbital cellulitis, because they are the ones who come in primarily in contact with the patient in the emergencies. So they should, the features which have been discussed are very important. And as far as what was your question about the culture part?
Yes, ma'am. Whether you routinely do blood cultures or
Routinely we don't do blood culture. It is only if the patient is not responding to the treatment which we've started initially, then only we go into these things. Otherwise, generally preceptal, they generally get cured, and or even the cellulitis, if taken care properly, even that time also we don't need, but if we required, we can definitely go with the blood culture and all. And as Dr. Raman had showed about the management of dacroadenite, IgG4, all these tests should be in our mind whenever we are treating cases of cellulitis or inflammation of the orbit.
Right, ma'am. Right, ma'am. Niba ma'am, your comments?
Same comments, because we belong to the same department, so we basically follow the same protocol. And we put the patient directly, we're suspecting an orbital cellulitis, we put the patient directly on, broad spectrum antibiotics, which covers gram positive, MRSA, and anaerobes. So that is a protocol. That's how we start the treatment if it's an aggressive orbital cellulitis. In preseptal, we don't start with such an aggressive antimicrobial, but we give at least anaerobes along with ceftriaxone or something like that. So that covers majority of the cases. So we don't really do any aspirates or whatever, unless and until we are suspecting if it's a mucor or whatever. Then we, of course, send the patient to the ENT, and if they need be, they do a FES and then send it for the nasal biopsy and all. Otherwise, this is the protocol. Yeah.
And nowadays, mucor is still persisting. It
Yeah.
is not that it has gone away. I think 2 or 3 patients we are having every week. So we have, and I am seeing PL negative eyes also, and the need for exenteration is also still there off and on. So mucor should be definitely in mind, and aggressive treatment should be started once you suspect it initially only.
Right,
Yeah.
ma'am.
And to add
That
on
is
to
the
that,
point
even
Dr. Sumit was
we've
also
seen. To add on to that, in our department side, we've seen patients of mucor nowadays which are not immunocompromised. They are
Yeah.
not diabetics, nothing. We cannot elicit even any history or any signs of immunocompromisation, but still they come up with mucor. That is again become, I mean, it's now a routine. Things which we never saw pre-COVID. It was one of the very rare things which we saw ever, even in our PGs or in our post-PG, clinical practice. But now it's become common. I mean, if you're into oculoplasty, orbit and all, so it's a thing which we see off and on, definitely mucor now.
Right, ma'am. Right, ma'am. I just have one question which is open to the panel. One last question, because being an anterior segment surgeon, so are there any subtle signs of a subperiosteal abscess in infants that might be mistaken for a viral conjunctivitis?
See, mostly abscesses, they come up with, either restriction of movement or maybe a proptosis or, restriction of movement like that. So if you have something like that, then only I think we should go in for, at least I've not seen any patient with a general, you can sign just conjunctival chemosis or whatever, and then it comes out to be a subperiosteal abscess.
Right.
No, I have not seen as such.
So pretty rare in clinical practice. Basically,
See the subperiosteal abscess will always come from behind, as she is rightly mentioning. So conjunctiva will be last to be involved until unless there are some associated inflammatory signs or something. So subperiosteal abscesses generally lead on to the proptosis. So proptosis could be one of the initial signs rather than you having the conjunctival chemosis or something.
Another thing which is very, very important is the role of steroids. Like, we are hesitant to give steroids in infections, but it goes a long way to control the orbital inflammation, especially once the infection has settled. So we should not hold back on steroids, especially.
Yeah, that's what I mentioned in my talk.
Yeah.
Because in some of my patients whom are coming from abroad, there they don't give steroids to the level they need to. So
Yeah.
what happens is that the disease becomes refractory, or it becomes into a chronic stage where you can't do much about it, and it lands up into a fibrotic stage of the disease.
Sometimes
So-
inflammation does more damage than the infection. So we need to control the inflammation.
And here, just to add, the orbital inflammation is again a mystery. You never know what infection. Like we had a case series which we published where we had patients coming from the landslide. Almost 15-20 patients were there, and we got call for three of the patients where they had some kind of a fracture and they had undergone amputation, and everyone had a typical finding of CRAO. So you are thinking in terms of mucor again, it's vascular, but they deteriorated in front of us in 2 to 3 days. And one of the patient in their amputation biopsy found to have a gas gangrene, and all of them had developed orbital gas gangrene without a penetrating injury into orbit. Of course, they had a then severe infection. None of them could survive. But like I said, the orbital cellulitis could be any infections. So of course, your antibiotic and steroid go hand in hand, but you need to see that in 48 hours to the antibiotics, your orbital
Yeah.
cellulitis is at least partially responding. In terms of at least systemic things like your TLC are reducing, your inflammation is reducing, those kind of things.
And another thing I would like to add on for the PGs is what the general norm among PGs at least is that they will start on the oral steroids for any reason, like could be any inflammation or whatever, and they right from the initial start they start tapering it. So I always tell them once the effect with a full dose of steroid comes, till that time do not taper the steroids. Once the effect starts coming, then you can slowly taper it off. That should be actually understood by the PGs because they are the ones who are actually even if we are not we are busy with the other cases in our practice and we don't just see at every follow up sometimes, so but that should be given note to the patient, to the PGs at least.
Ma'am, very often we find steroid responders these days. So whenever we give a loading dose of steroid, we always advise for fasting blood sugars on a daily
That's
basis
there, of course,
in the
yeah.
cases of admission, otherwise in the follow-up as well. I can tell you some 70 to 80% turn out to be steroid responders.
So I think we can all agree to the fact that the landscape of oculoplastic surgery is changing fast, and the cases which were considered as uncommon or rare before COVID are now more frequent in the clinic, and it would be wise to keep our eyes and ears open for the general practitioners as well who are watching this, that not to dismiss our clinical intuition as being, wrong. Maybe we could be looking at something that was considered rare or uncommon some years back, but is not so anymore. Right. So, with that, I think we'll close the session for the day. A heartfelt thank you to all our distinguished speakers, our panelists, for illuminating the complexities of orbital infections with your expertise and your practical wisdom. Your contributions from discussing imaging nuances and debating surgical thresholds and treatment thresholds and emerging new threats have enriched this session and have equipped clinicians and residents with actionable strategies to tackle these vision threatening emergencies. And for sure, your oculoplasty passion shines through, and we are profoundly grateful for your time, dedication, and interactive engagement that made this webinar truly enriching and outstanding. Thank you very much. Have a great evening, you all.
Thank you, Inder sir,
Thank
and
you.
wish you all the very best, Raman sir and Urbil ma'am.
Thank you.
Thank
Thank
you.
you.
Thank you,
Thank
We
you,
ma'am.
need
ma'am.
your
And
support.
good evening, Niba ma'am and Urbil ma'am. It
Yeah,
was nice
hi,
to
hi.
be in your
Thank
session,
you very
ma'am.
much.
Dr.
Really
Swati,
properly
which place
obliged,
are
Yes,
you
ma'am.
from?
Sharmishta ma'am, thank you very much.
yes, you asked me something.
I was asking about Dr. Swati. Which place are you from? I was not aware. I think
Dr. Swati is
you're
muted.
muted.
Dr.
You're
Swati is
muted.
muted.
Yeah. Which college is she from? I didn't know. Anybody can tell me.
Swati
I
ma'am, would you like
practice in
to
Gurgaon, ma'am.
Okay, you practice it. So you are
Yeah,
Haryana,
yeah.
really. Very bad. I don't know. Very bad of me. Chalo, thank you. Thank you for
Thank you
being
very
there.
much.
And
Thank you, Raman
definitely
sir.
Yeah.
Thank
Bye-bye.
you.
Thanks, sir.
Good
Thank you,
night,
Thank you,
Raman.
Raman
everyone.
sir. Thank you, Rasogi sir. Thank you,
Thank
Amita.
you,
So,
Dr.
Sumit, it is
Sumit.
very nice to see you after so long,
Always nice to see you, sir. Always nice to see you.
You're
Thank you.
there
Have a
in
great
Kochi.
evening.
Thank you,
All of
Indra
you
sir.
Amita, a
involved.
Thank you, ma'am.
compliment for you.
Thank you, Amita ma'am. Thank you so
Amita, a
much.
compliment for you. You're a very good moderator and you come up with really good questions for the panel and for the chairs,
Thank
co-chair
you
and
so much. That
chairperson.
is
We
so.
Really.
have a
It's
Yeah,
wonderful flow
despite
as
being
well.
cornea specialist, all the good questions on the
Yeah,
ocular
the
side.
good questions.
thank you so much.
Before we end, I invite you all for the upcoming OPI annual conference at Kochi. Okay, so Marian is organizing. You can have more of these type of discussions there. It's a wonderful platform to be in.